All right, good morning, everyone. My name is Wes Gibson. I'm one of the communication co-chairs with the Health Equity Collective. Thank you for joining. Normally on a monthly basis, we host a virtual networking session centered around a variety of the topics we're addressing in the Health Equity Collective. Yes, so said before, we will record these sessions on YouTube so that everyone has access to it later. And without further ado, today, one of the co-hosts and director of the Center for Health Equity, Dr. Srila Sharma, will be directing the session. So I'll go ahead and turn it over to her.
Thank you, Wes, and welcome everyone, and welcome Dr. Humphreys. It's very exciting to have you here. I also have the privilege of co-leading the Health Equity Collective, which is the systems coalition in the greater Houston region that's focused on how do we improve care coordination for social determinants of health. And one of the areas or work groups has been around mental health and substance use disorder. So we're very excited to have this conversation with you today. Our format today is a little bit different than our usual networking session. It's more of a Q&A type of a format that we'll have. There'll be some questions. I will start by moderating and asking Dr. Humphreys, but then we want to open it up to everybody on this call and just have a dialogue with Dr. Humphreys. So feel free to turn your cameras on and we'll get into the conversation. So to kick us off, I just want to introduce Dr. Keith Humphreys. He is the Esther Ting Memorial Professor in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. In addition to over 400 scientific publications, he has written extensively for outlets like the Washington Post and the Atlantic. We greatly enjoyed reading those publications. He has advised multiple US administrations on addiction policy and has been involved in significant policy developments, including the Affordable Care Act. Internationally, he has contributed to drug policy in the UK and served as an advisor to the World Health Organization. Dr. Humphreys has received many honors and awards, including in 2021, when he earned the Undersecretary's Award for Outstanding Achievement in Health Services Research, the highest honor for a U.S. Department of Veterans Affairs Health Services researcher for his work to improve the understanding of factors that affect the health of veterans and the quality of their care. So it's also a great week to have this conversation in honor of our veterans as well. So thank you so much, Dr. Humphreys, for joining us today.
Thank you for that kind invitation and nice introduction, and looking forward to getting to know everybody.
Yeah, well, let's dive in. I think we're all really curious to know how you got into this space of working with addiction and policy, if you can share with the group.
Yeah, so as is probably true in many lives, there was a lot of happenstance involved. I was an undergraduate. I was majoring in psychology. I was flipping burgers to pay my rent. And I didn't really know what in psychology I wanted to do. But a friend of mine came into the Wendy's, and I was wearing a Wendy's costume, and she looked great in normal office clothes, and I was covered in grease burns, and she looked clean, and I was very envious of her. And she said she had a job in the medical school, but she was graduating, and she could recommend me for that job. And I said, what did the job pay? And she said $4.40 an hour. And I was making $3.35 an hour, which was the minimum wage. And she said, it's a project on addiction. And I said, oh, I've always been interested in that, which was a lie. I would have said that for anything, And so I often wondered, what if she'd said schizophrenia or depression or cancer? I would have said, I've always been interested in that, because $4.40 an hour is what I was interested in. But that's how I got into the field. And then why did I stay in the field? Because I could have done that by happenstance and not stayed in. I find it's very compelling in two ways, to the head and to the heart. So from a head point of view, it is a fascinating mystery about human beings that we will say prioritize some grains of powder that have no nutritive value over food, water, shelter, the care of our young, friendship. And that is just a mysterious thing that we do that. And why do we do that is a fascinating mystery to study. Then in the heart level, I find working with people who are addicted very compelling. It's everything interesting about the human experience you see in addiction writ large. You see love and redemption, you see pain and struggle, difficulties with control, searches for meaning, faith, family, everything. So I find that really compelling. And that's how I got into that. How I got into the policy part is another happenstance. So you probably all remember the summer before you went to graduate school as the last happy time you had for some years, last relaxed time. First day of that summer for me, I suffered a very terrible accident and playing basketball and had suffered a spiral fracture of my femur. So I was in traction and I couldn't walk most of the summer. And so all I could do was read. So I read a lot. And I read a book by Seymour Saracen, who was a psychologist at Yale, who persuaded me that if you wanted to help people, it was certainly noble and good to do what I was planning to do, which was be a psychotherapist, but that you could affect a lot more people if you could change the rules and policies. So, I had done work, for example, with victims of violence. That's certainly a good thing to do. But if we could reduce the amounts of violence in society and not have those victims become victims in the first place, that would be better. And that persuaded me. I was intellectually persuaded. If you ever wondered whether your writing can change someone's life, it changed my life. That book did, and reading about that thought. And so I started to try, starting as a grad student, where I got to know the mayor of the town, and we were doing some work to try to improve the quality of public housing. I always have tried to connect with the policy structure that drives mental health and substance use. And then that was built on further when I came out to California, because the VA is a national system. And within a few years, I was running the center that oversees all the data and evaluation for the VA's national substance use care. So I was doing things like working with congressional staffers and VA undersecretaries and things like that. And then, as I did that and went to Washington more, I just sort of met more people, and I was asked to serve on more, White House commission. And I said yes, and things kind of build on themselves. And now I've been doing it for a very long time. And probably the most consequential thing was also just, again, luck, that my friend Tom McClellan was friends with then Senator Joe Biden. When Senator Joe Biden ran with Barack Obama, called my friend Tom and said, I want you to come to Washington and do health-oriented drug policy. And Tom called me and said, I don't really understand policy, but I know that you do. So why don't you come with me? And so that was probably, again, luck, happenstance. But spending a year in the White House was, quite consequential, not just because of the work, but because I met a lot more policymakers, people I still work with today, and have a pretty strong network of them that we try to maintain through the university, a mixture of scientists and policymakers trying to learn from each other about how to approach all types of addictions.
Thank you. So good things can come out of working at fast food restaurants.
There you go. All started at Wendy's.
Yeah. And also highlights the importance of networking and establishing a solid network in terms of furthering that goes to these type of sessions that we have. We also have students who join these calls. Good. So we emphasize the importance of establishing a strong professional network. So your attestation certainly lends to that as well. So thank you for sharing that background. I guess taking it, if we continue along that same thread of addiction and policy, what about substance use specifically merits a different approach to policy, say, as compared to some of the other things that we're working on, like chronic conditions or even depression? Can you share a little bit about your thoughts on that?
Yeah. Substance use connects to everything. So unlike, schizophrenia is a very important illness to study and work on, but it doesn't have you couldn't really sit down at a table where people were discussing the unemployment rate or crime or housing or child well-being. And you could say a little about schizophrenia, but not a lot. But substance use is a big part of all of those things, and economic issues and infectious disease. So it's very important across the whole policy space. If you like policy, it's good to be interested in. The disorder is different than many other disorders that the healthcare system treats in two very important respects. First, it creates huge externalities for other people. So high blood pressure, that's a problem, but maybe your loved ones will worry about you a little, but for the most part, they won't even know you have high blood pressure. But everybody's going to know if you're addicted to alcohol and cocaine, and they will experience harm from that. So that makes it normative that the stakeholders are a lot broader for wanting services, wanting treatment, wanting recovery than you might have with high blood pressure. The other part to it is because it does affect the brain and how we value things. The person concerned is often far less interested in behavior change than the people around them. They're consuming a drug. Yes, their life is falling apart, but that drug feels good. That's what addiction is. I keep doing it even though it's causing trouble. And so as a result, counting on people to sort of spontaneously wake up one day and say, I really like to seek treatment, there's a really good chance that'll never happen, that they'll die before that point, which is much less the case with other illnesses that are more subjectively awful all the time. Like, you don't have to persuade anyone with chronic pain. Would you like to get rid of your chronic pain? Everybody would like to get rid of their chronic pain, or their bad back, or their bulky knee, or their depression. But people in substance use are much more ambivalent. And that's why, so in this space, the fact that you have that ambivalence about change and you have a lot of external people being hurt, that's why there are policies to push people towards treatment that you don't really need for other types of diseases.
Very interesting. And along the same lines, if we can go sort of one layer into, you had a very interesting take on the systems level responsibility of pharmaceutical companies and prescription painkillers.
Yes.
And can you speak a little bit to your thoughts on that particular issue? Because I think that's a very compelling argument that you put forth.
Yes.
Yeah.
I'm glad you brought that up, because that's another domain that's very important for substance use. No one sells depression, right? But people sell all the drugs to which human beings get addicted. And therefore, they have to be regulated properly. And part of what happened, why we had an opioid crisis, was clearly due to bad behavior by the for-profit companies who make pain medication and deliver pain medication. The distributors did a lot of bad behavior, and really great failures on the regulatory side. So we wrote a report, a Stanford Lancet commission on this, and one of our points was it would be wrong to say what happened was people, there were people in the black hats and the people in the white hats, and the people in the black hats overcame them. The people in the white hats, a lot of their hats were gray. They were opening the doors and letting them in. They were often half in on it, or they were just asleep. And why is that important to figure that out? Because there's no reason why the same thing can't happen again with another drug, benzodiazepines, gabapentin, or ketamine, or whatever new drug gets developed tomorrow. And I just give one example of the sort of what we're up against. The companies that ship drugs, so they ship, they were doing things like delivering 1 million pills to towns with 300 people, like where I'm from, West Virginia. And the DEA stopped them and said, you're not allowed to do that. That's a very suspicious shipment. Why would a town of 300 people have 1 million opioid pills a month? And cited them and said, you're going to have to, we're closing down this, this warehouse. You can't make these shipments. The companies went to Congress. They also hired away some of the DA's employees to work for them as lobbyists. They went to Congress and basically got that power stripped from the DEA. And that passed the Senate 100-0. Everyone voted for it. So that's one of the challenges when we don't have this with illegal drugs, but with legal drugs, legal companies have a lot of power in the United States because they have money, and that's the way our system works. So that's a real enduring challenge that we don't have for a lot of other illnesses.
Thank you. And so talking about, you spoke a little bit to the challenges. What successes, what are some of the examples of successful results that you've seen, especially when we talk about state or local policy or federal policy response that you may have seen in this space of substance abuse?
So from 2008 to the present moment, we've had the largest expansion of health insurance for substance use disorder in the history of the country. In fact, it's grown more in the last 15 years than the prior 150. We had the 2008 mental health parity law, which I worked on with a lot of other people, that large companies had to have benefits be comparable for mental health substance use as other parts. Then in the Affordable Care Act, that gets extended to medium companies, small companies, also individual plans sold on state health exchanges. It goes in Medicaid expansion also. Also 2008 Congress, traditional Medicare outpatient gets comparable reimbursement, which you had never had before. CHIP has it. And this has been pretty popular. It survived multiple Congresses. It tends to succeed with a lot of votes from both parties. The further thing that has happened that is very good, and I credit the Biden administration for this, and I hope the Trump administration will continue this, which is better enforcement. So most of this enforcement is done through the Department of Labor, small amounts done through HHS and Treasury. Mostly it's the Department of Labor. And having them really take on cases where families have been, let down by the insurance company. Your kid's addicted. Your insurance says you're supposed to be able to get residential care, and then you're literally kid's been turned away at the door, and they say no, you could be a 30-day review period or something, and the kid dies in that period. There's a lot of cases like that which are horrible. So that's what like as with all regulations, you have to have enforcement to make the private sector follow them, and so they've been enforcing that much more, and that's good. And it probably wasn't accidental that the guy who was the head of the Department of Labor was in recovery, the secretary, Marty, gosh, I'm blocking his last name. He was the mayor of Boston. Walsh, Marty Walsh. And so that's sort of, I think, helped complete it. I was working in the last Congress on, the final pieces of this, which are at the moment still Medicare Advantage plans. These are the private plans that Medicare are not subject to parity. And neither is fee-for-service Medicaid, which only covers about 10% of people, but it does cover pretty vulnerable people. So it would be great to just get that done so that parity is as standard as, like I'm here in a hotel, the hot water is always on the right and cold water is always on the left. Any hotel, that's the way it's going to be. And that creates an industry standard. And also you immediately know if something's wrong. If you get cold water out of the right, something's wrong. And so we want to have that with health insurance, no matter what insurance you're on at different points in your life, you just get mental health and substance use parity. That I think should be the industry standard for health insurance in the United States.
Yeah, and the hot water on the right and cold water on the left, is that what we have? Might look different in Europe, and it looks like Europe also does things a little bit differently in terms of decriminalizing some of the drugs, and Portugal being an example that since 2000 has decriminalized drugs, and we seem to have tried it in a state or two, but it seems like it's a tall order here in the U.S. Can you explain why?
Yeah. Well, a very interesting thing I just heard, when Oregon decriminalized, the advocacy organizations that were trying to, when it looked like it was going to be repealed, they actually flew all the legislators to Portugal, paid for a junket, which convinced them it would never work in the United States, paradoxically, because they saw that Portugal added a lot of things to it that the advocates refused. So Portugal is, I was just in Portugal, I've been there a lot. Got to remember, it was dictatorship in living memory. It is a communitarian, Catholic inflected culture. It is not an individualistic culture. It is a huge emphasis on families. Large numbers of people, if you meet in Lisbon, were born in Lisbon, and their mother lives in Lisbon, and their father lives in Lisbon, and their grandparents live in Lisbon, and they're in touch. And there's love. There is also monitoring. So why you wouldn't want to use heroin on the street of Lisbon? Yeah, the police could get in trouble, but your mother could find out. and your priest could find out, and so there's a lot of social constraint in that culture. And so they didn't decriminalize drugs in the sense of like drugs were great. They were like, drugs are bad, but we want to try to reintegrate people in society, and we think a criminal record will harm that. But it was still a very, sort of paternalistic policy, and particularly because if you use drugs on the street, the police can just grab you and take you to what's called a dissuasion commission, and that's a panel of people. Would be a mixture of health professionals, typically, maybe a law informed person, who will do an assessment, and they can say it's just a one-time thing. Don't do that again, Keith. Go and sin no more. Or they can say you seem to have a significant problem, and you need to go to treatment and stop using drugs. And if you don't, there's going to be consequences. They're not going to throw them in prison, but they can fine them. They can constrain a license, so they can say you're a cab driver. As long as you're using cocaine, and we're not going to let you use your cab license until you get yourself in shape. And it's interesting, the advocates in the US, more libertarian, looked at that and said, no, they did not want that. So they removed a central piece, but they said they were doing what Portugal did. They aren't. So instead, they had a culture that is far more individualistic, far less family oriented. Huge number of people on the West Coast are not from the West Coast. They don't have families constraining them. Often people come here to get away from constraint, right? So you have all that, you remove all legal constraints, you remove even this nudging system, and essentially nobody was interested in treatment. They had a system where you could write a ticket, same situation. Instead of the cop picking you up and taking you to the dissuasion commission, all the cop would do would be write you a ticket, which was a fine of up to $100 with a 1-800 number. If you call the number, you and get a health assessment, the ticket will be waived. But over 90% of people didn't even do that. They just threw the ticket away. Of course, they just threw the ticket away. And it was really crazy to think that somebody sitting on a park bench would say, well, because of fentanyl, I've lost my family, my job, my health, my home, and my dignity. But now I've got a ticket for up to $100. I'm really going to turn my life around. This is the straw. They've given up way more than some stupid ticket. And also they probably knew no one was going to make them pay it, which they didn't. And they had a hotline that was staffed by all these people ready for all these calls. None came, or virtually none came. So they ended up costing the state $7,000 per phone call. That's how much money they spent relative to the uptake. And there we go back to this thing we started with, which is addiction is different than other conditions. There are not people beating down the doors to stop using drugs like there are people beating down the doors to get rid of chronic pain or cancer.
Thank you. And that's it goes to the social, cultural, environmental constructs that shape our lives in such a significant way.
Absolutely.
Which takes me to a question that in our region, we have been exploring across many of our domains of work, and that is stigma.
Mm-hmm.
And one question we had for you was, we wanted to pick your brain on what role do you see, how do you see stigma manifesting in substance abuse and recovery policies?
Yeah.
And what is the evidence around that, especially as, in terms of implementation of these policies?
So it's very common. You can pretty much say we need to reduce stigma at any conference in our field, and everybody will nod their head. But I often wonder, what is each individual person thinking? Because it's stigma about what? There's nothing inherently wrong with stigma. When I started my career, telling sexist jokes at work was common. Now it is stigmatized. Good. Drink driving was the subject of jokes. Now it is stigmatized. Good. I mean, stigma is how we set guardrails to make life better, right? So stigma about what? And I think the thing we want to destigmatize addiction, and we want to destigmatize seeking help for your addiction. But we do not want to destigmatize fentanyl use. We still want to have prevention programs that say, this is not just some other leisure activity. This is really, really dangerous. People who do this have a mortality rate of about 5% per year. It's super dangerous. And that is a stigmatizing message. You were saying something bad about it. but I think we should say something bad about it. And, I don't know if you saw, I had sort of a disagreement with the San Francisco Health Department that put up billboards to try to destigmatize not addiction, but use, in the same way that beer companies try to make beer attractive. They tried to make fentanyl look attractive. And I thought that was a mistake. There's a lot of, the other parts of this is, let's go back to where we started. There's a lot of externalities to addiction. Many people have been hurt by an addiction. I've been hurt by addicted people in my life. I lost a dear colleague when I was at that first job, who was killed by a drunk driver who'd been arrested for drunk driving 3 or 4 times. So many of us have been hurt. And with that comes anger and frustration and, and pain. That is where a lot of the stigma comes from. So when people, I think it's not in our field, we tend to treat people who have negative attitudes about addiction as stupid or misinformed. They just don't know the neuroscience. But I find often that it's much better to say, what has been your experience of interacting with it? And then you often hear there's a story. And when you express compassion towards that person, suddenly their heart opens up and they can start to be compassionate for addicted people. But if they feel they're being sort of, flogged for having the wrong views, they just shut down and they get very angry. And I just tell a story about this. My dear late friend Rich Seitz told me this story. He did an event at the National Press Club, and he did the usual kind of night of viewpoint of, this is a brain disease. You shouldn't feel anything negative. People can't help it. You need to stop being so blaming. And afterwards, a journalist came up to him and started crying. She said, my husband was drunk most of our marriage. He broke my nose 2 times. You care about him and you don't care about me at all. And Rich felt so ashamed, and he realized how that speech sounds to people who have been hurt. And I really take that to heart. I think that's where a lot of it comes from. Not all of it. Some of it is misunderstanding, but a lot of it is pain. And I listen to that first, and I find that is far more effective than billboards and all the campaigns we've done, which, as far as I can see, have had no effect anyway. Because it's not about a rational process. It's about, I've been hurt and I'm angry.
Thank you. And thank you for sharing that story as well. A related challenge that we all see in this space around addiction and substance use is homelessness. And policymakers struggle with that because that's a very visible issue, right? And so would love to hear your thought. And I think that's my last question. I don't want to take up all the space. We will open it up to questions from the audience, but would love to hear your thoughts around how should policymakers be thinking about housing models or addressing homelessness and substance use. So yeah, if you can speak to that.
Well, I guess someone from the San Francisco Bay Area telling people from Houston what good housing policy is, it is like, me telling Roger Federer how to, improve his backhand. I mean, Houston is the city that everybody here talks about because, you make it possible to build housing and you invest a lot in getting people into housing. So you're doing way better than we are where I am. So I think we should be taking a cue for you. I mean, and I'll just say the meta point, I think, is that independent of addiction, if you make it impossible, virtually impossible to build housing, someone is going to lose that game of musical chairs. And they're more likely to be addiction-proof. So some of this has nothing to do with addiction, it has to do with housing policy and housing markets. That said, if you are addicted, it is easy to lose your housing. I'll just tell you another personal story. A wife and I had a friend who called us paranoid from the street, a street payphone in San Francisco. He had been using a lot of meth, and he believed that there were people living in the walls of his house who were watching him, and he was afraid to go home. And so we had to take him in. It took him about a month to detox in our house. Now that's a great example of that. Like that, he was homeless, but he had a home. Addiction can drive people out. Also, families sometimes throw people out. They can't take it anymore. They get really upset and angry, or the person steals something, they get mad and they sort of punish it that way. So it is not true, as is sometimes said, this is just a housing thing. It's addiction actually can make people homeless. And of course, homelessness can make people addicted. You start living in a community, a tent community, where everybody's using drugs. There's a lot of theft, a lot of sex work. That becomes normative, and then you're more likely to get into those behaviors, as we all are shaped by the people around us. So rather than get into the fight that we have out here, which is it one or the other, you just got to say this is both. It's very much like when people argue about dual diagnosis. Is it mental health or is it substance use? Both. It's both. So at the market level, we need to have more housing. We need to also, in California, have some housing that supports recovery. So I'm very impressed with Leonard Jason's randomized trial of Oxford House, that people there with a lot of problems who go into Oxford House and live there are way more likely to stay off of drugs and alcohol, way more likely to have a job, and way less likely to end up in prison again. So we need housing that is therapeutic. Our challenge in California is that is currently illegal under state law. We have housing first. All state dollars have to be spent on housing first, drug tolerant housing first. I'm in favor of housing first for lots of people. I mean, especially for people with acute schizophrenia. What else are you going to do? But I would like to see some therapeutic residences where, like, I volunteer at a St. Anthony's Foundation. We have a year residential program. When people leave, I would like to be able to see them go into a housing where there is no drugs and alcohol. Instead, what happens in San Francisco is they go into a single room occupancy where there's lots of fentanyl use around. It's very easy to relapse, also very easy to overdose, and alone, and then you die in the SRO. So I did work with a legislator last year. We got to just allow up to 25%. So there would still be plenty of housing first. It got trimmed, but the advocates of housing first really hated that. They trimmed it down to 10% and then killed the bill. So it's an ideological thing that we need to get past, that I think they would say, you need to respect people's rights to use drugs and alcohol. And I would say rights are important, and also all these people are dying. And I think that violates their rights. So I want to have some therapeutic place. And also, I know that a lot of the people who need the housing want that too. It's not just some professor imposing it. Like when people are leaving our program, they do not want to live in a single room occupancy where everybody's using fentanyl. They really would like to live in a place with other people who are trying to recover, who can sort of go on that journey together.
Thank you so much, Dr. Humphreys. I'll turn it back to Wes to moderate the rest of and open it up to our audience for the rest of our Q&A session. So feel free to unmute yourselves and ask questions to Dr. Humphreys as well.
Great, yeah, and if we have several, if you're able to, please use the raise hand feature, but go ahead and open it up. Does anyone have a question? And if you're unable, if you're on the road or something too, feel free to type it in or message if you can't ask it out loud yourself. Okay, Marilyn?
Hello, hi, good morning, everyone. My question here is just, I'm hoping I didn't miss this towards the beginning, but what's your overall, I guess, what would you say as far as when we talk about harm reduction or supervised consumption, what's your view on harm reduction?
Well, I take the same view that the United Nations does, that it's one of the 4 pillars of drug policy. So you have harm reduction, treatment, you have prevention, and you have law enforcement. And the first statement by a president to get naloxone out of the hospital and into communities, I wrote. So I've worked a lot. We lifted the ban on federal funding of needle exchange programs. So I've worked in harm reduction for a very long time. I think where it has gotten ineffective and unpopular are in places where it gets fused with a more libertarian view, such that treatment and recovery are not important. For example, a friend of mine from New York Times came up to San Francisco and we spent a day together. He was interviewing a harm reduction worker. And he said, what would you do if someone said, I'd like to get into treatment and stop using drugs? Harm reduction worker said, I would discourage that. Treatment is not something, they can never stop using drugs. They shouldn't need to stop using drugs. Society just makes them feel that way. And it's like, okay, that viewpoint, I think is, well, I don't think that in the end has good outcomes for people, but I also think it's just unsustainable. I mean, the rage across the cities that have pursued this, San Francisco, Portland, Seattle, Vancouver, is palpable. And the politicians who have been associated with it are all been voted out of office. So I think we need to think of harm reduction as a public health tool that is with the goal and the hope that every person will get to a state of health, not just live for 24 more hours. It's good, obviously. I carry naloxone with me when I work in the Tenderloin. I will rescue people, but it's to aspire to more than that. And I sometimes think that if you talk about stigma, the idea that we shouldn't hope for recovery actually seems to me to originate from stigma. That the most anyone can achieve in life is to be a slightly more functional addicted person. That's the limit of their success. On supervised consumption sites, what I would say is they are a boutique intervention that has failed at a population level. And by what I mean, by that I don't mean they don't help people. What I mean is the first one started 40 years ago, and the entire planet hasn't even built 200 of them. And that includes lots of different countries with different cultures and different systems. So that's really boutique. If you compare that to methadone or needle exchange or treatment, you're never going to affect the population that way. And we know that when the sites are created, very few people go unless they live right there. People don't drive into town to use their drugs at a government facility. So what I'm doing now, I'm working with a really bright Canadian physician who does this remotely. They've got a team of people. And so even somebody who lives in like northern Saskatchewan, 2 hours drive from anything, can call them or Zoom with them, and they talk people through their drug use experience. And if somebody overdoses, they call 911 to help them. That seems to me far more scalable because a small number of people can cover huge swaths of the country. And you don't have all the community opposition that you have. No one even knows what's going on. So I'm impressed with that model. I'm impressed with how many people are really happy to do that. Like they really are willing. They have to. They're taking a risk, privacy risk. They're also, they have to let the team know where they are. But they've had hardly any false call outs and they've saved lives. So that I think is a much better future than putting so much effort goes into building these sites, and they're not really politically viable, and they don't touch the population at a level that I think we should focus on other things that are more likely to have a bigger population effect.
Thank you so much. Thank you.
Andrea or Andrea?
Thank you very much. Andrea, it's correct. Dr. Humphrey, first and foremost, I could definitely feel your passion through the screen. And I do have a question. What is one model that you've seen within a family that does have a substance use disorder be effective?
Within a family?
I have, within a family. I have heard of plan of safe care that some states are doing. Have you heard anything behind that, or any other models that you feel have been successful to bring in the unity of the family with a substance use disorder? And let's say mommy or daddy or just one of the parents. Yeah.
So I'm not familiar with that model. The model that I know the most about is CRAFT, which Myers has done a lot of pretty compelling trials of. I think Myers is Meijers. I think that's how you spell that. He was, I think, in New Mexico. But that shows high levels of people, the family working together to get people into treatment and, with good outcomes all the way around. I also will tip my hat to the fellowships like Al-Anon. I think it is very interesting how they deliver exactly what they promise. I mean, so every study of them shows that participation, whether it's spontaneous or driven by a randomized invitation, reduces depression, fear, anxiety, and resentment. And so often, all of us get these calls from the family members, and we're not talking to the person concerned. They're not interested, but this person is falling apart. And I always say, well, I really wish I could change this person for you, but I know that I can't because I know you've been trying and you're there and you can't. But there is something we can do, which is let's get some help for you. And I always suggest, why don't you try Al-Anon, meet other people in this, or the Nar, whatever the appropriate one is for that person. Meet other family members in this situation, and it's good for your mental health. And in the long run, your mental health getting better should have some positive effects on the person you're worried about. But the main reason to do this is for you.
That was beautiful. Thank you very much for that information. I appreciate it.
Thank you.
Anyone else have a question? Here in the chat I have from Maureen. Can you clarify on how policy effects and effectiveness differ by age, gender, race, and ethnicity?
Yeah, so I think, everyone on this call knows there are good treatments, but you can't get treatments if you in the United States if you don't have insurance. And we have pretty consistent and massive disparities in race and income for getting health insurance. Every study I have seen of the Affordable Care Act has shown it is a force for equity. So people, whether it's cancer care or heart disease care, the gap, particularly between Africans, Americans, and whites, is a lot smaller on all those illnesses because of the Affordable Care Act. We need to, in my opinion, we need to complete that revolution so that that gave, coverage to 62 million people, better mental health and substance use coverage. We need that for all Americans, in my opinion. So that to me is the quickest, simplest way to make sure every single person can go to get help, regardless of their income, their race and all that. I believe in markets. I know they can do lots of stuff. I don't think, though, they've worked very well for healthcare. I think what we have is a very expensive system that still a lot of people can't access. So that is the big change I'd like to see from a equity viewpoint. There's plenty of other things we could do, but that's the big one. Make sure everybody has insurance.
Suzanne?
Good morning. Thank you so much for joining us.
Happy to.
I'm with the Houston Recovery Center. We run a pre-arrest diversion program for public intoxication. So your statement about diverting people to an intervention through policy really can be very effective. We are all lived, experienced based staff here. So they're coming into a recovery-friendly environment. And we've had some really good results. We've built a long-term recovery program on the back end of our intervention.
Awesome.
For people who really wanted to stabilize. So I love everything that you've had to say today. I wanted to know if you're familiar with the Alliance for Addiction Payment Reform. They're trying to incentivize recovery through new payment models. An addiction recovery medical home. Are you familiar with that at all?
I am not. I've not heard of that group. Is that a Texas group or is that a national group?
No, it's a national group of recovery advocates that are trying to build a payment model that merges healthcare with recovery services to incentivize recovery. It is a pay for performance outcome. So there's a lot of risk of people going into the model, especially, with addiction, which can take a long
Sure.
time for people to stabilize. I don't think people really realize that if someone goes an abstinence pathway, it takes 18 months just to get to a point where their return to use rate is very low, and then another 3 or 4 or 5 years to actually get into long-term recovery. But the way addiction recovery is delivered in all these silo-based services, go to detox, and then you have to go to treatment, and you go to all the outpatient stuff, and then you've got the housing and all of the social determinants of health that have to be put back together for people. So I'm just wondering how much the current payment systems are holding addiction in place rather than incentivizing recovery itself.
Yeah, so that's a really good question. I don't know if everyone on this call is a substance use focused person. So let me, at the risk of boring some of you, just let me describe the sort of funny financial situation we have, which is for a very long time, substance use care in the United States was paid for almost entirely through what's called the block grant at SAMHSA. So SAMHSA is an agency at HHS. It would give this block grant, which is not a lot of money, to states. Some states supplemented it, some states didn't. And that's where it came from. So this is unlike any other payment system. There's no block grant for cancer. There's no block grant for cardiology. Money structures things, right? So, we are all, that's our boss, the person where the money comes from. So that has made the substance use care system kind of a country cousin of the rest of healthcare, paid differently, evaluated differently, regulated differently. And then when you have a human being who needs care across that system, it's very hard to coordinate it. And my conclusion about that, and what we felt in the White House when I worked for President Obama, was that if you divide money up in Washington, you will never knit services together on the ground all over this country. So the best thing is for addiction treatment to be covered by the very same payment mechanisms as everything else. Like Blue Cross, like Blue Shield, like Aetna, like Medicaid and Medicare. And that surprised some advocates in our field, and I think probably made them mad, that we weren't that interested in the block grant. What we were interested in is being covered like everyone else. And that worked, by the way. Medicaid is a bigger payer for substance use care in the United States than the block grant. But it does still raise the question, let's say we completed that revolution. What do you do with the block grant? I think the perfect use of the block grant would be to cover the recovery support services that are really unique to our field. And my friend Tom Coder, who is when he was acting assistant secretary at SAMHSA at beginning administration, persuaded them to set aside 10% of the block grant for recovery services, which I think is terrific. I would go bigger than that, but I understand there was resistance to it. But that's where you could put things in that don't really fit in Blue Cross, like housing, like recovery housing, like a lot of peer support services, like the kinds of things the recovery community does that make life better, like running a community center and having a recovery music show or art show, or marches, or good activities that are good for health. That could be paid for out of the block grant, because you would have the more medical part, if that's the right word for addiction treatment, paid for by the same insurers who pay for everything else. That's what I think we need to have.
Thank you so much.
Thank
yes,
you.
Since we did not expand Medicaid here, we have the whole recovery continuum going after that block grant.
That's hard.
But I agree with you that we have to focus as much on the back end as we do on the front end, because treatment is just one step. So, and yes, I know Tom as well. He's an awesome guy. So thank you so much. Yeah.
Thank you.
Andrea?
I do want to ask for your just your take on what do you feel is the importance of having people with lived experiences on your staff, being your frontline staff, as well as part of the department of, whether it be the Houston Recovery Center or either also community health workers, as being out there recruiting or promoting naloxone. Is this something that you've seen increase throughout the years, or what's your take on that?
Yeah, thanks for that question. So I actually started my career, I was really interested in peer interventions, and a lot of the first studies I did were actually of Alcoholics Anonymous and Narcotics Anonymous, and they came out really well. I mean, the power of peers. And it's not that you need lived experience to help people, but sometimes it is the special sauce that makes the connection that no amount of professional training can. So, if I tell somebody, you could have a really different life, they could look, yeah, but you're a Stanford professor. I'm not going to, that your life is not my life. You don't know what it's like to be addicted, and I don't. But instant credibility from the person who says, look, I was homeless for 3 years and like you, and now I have a job and my family and I, are in speaking terms and all that, you can have this life. And also in the harm reduction area, you can be sure the person cares about you. They're out there because they are you. And this is, by the way, a really interesting thing to me is a long time ago now, I did some work over in the UK, in Scotland. I came over with a lot of American recovery advocates, people like Carol McDade and Bill White. And the UK harm reduction community got, very upset. These American recovery people, they don't like harm reduction. The recovery advocates were the most supportive of harm reduction. They were raising money for it because they think that could be me. They identify, they care in a way a lot of people don't. I think that's, this is as I said at the beginning, there's a head part to this, but there's also a heart part. And, people with lived experience can often make that heart connection very rapidly, and therefore they can do a lot of good. And we're doing a lot of that. So I co-lead what's called the Clinical Trials Network of NIDA for the Western States node with Todd Korthus up at Oregon Health Sciences University. And we have peers was actually the focus of our proposal renewal. We have lots and lots of peers doing all kinds of things, recovery support services, outreach and needle exchanges, naloxone, the whole works. Peers are powerful.
We have a question in the chat from
I appreciate that.
Dr. Scott Hickey. It says a significant proportion of our people with serious mental illness at our community mental health center also have substance use issues. Do you see policies that help or hinder the integrated treatment of these dual disordered individuals?
Yeah, that's a long and sore point that sometimes the compensations of the care financing system will pay for one disorder and not the other, or pay for one well and one not enough. Or what also happens is, I think the way we structure our professions and our services, people get caught between two stools, in that the mental health program wants to take them once they've stopped using substances, and the substance use program wants to take them once they've stopped having acute psychotic things. And they are catch-22. What we learned in the VA, after years and years and years of pleading with psychiatry and addiction services to work together and it not really mostly working, was that you just had to design the services that way. So things got a lot better when the VA designed and funded teams whose job was, our most common comorbidity, PTSD and alcohol. And so those groups to say, this is my job, this is what I'm paid to do, this is how I want to perform. And it was just a given that it was going to be dual diagnosis care always. That really seemed to make a difference. A lot of veterans came in. I think they did. I think those teams did really good work. And that worked better than preaching at the two camps to work together.
To find the raise my hand button. So someone previously had brought up plans of safe care. So plans of safe care are federal legislation included in the CAPTA and CARA legislation. Each state is supposed to define it, what that looks like on their own in order to promote child permanency for families impacted by substance use, specifically infants and toddlers. Texas has not defined that. And I think that just triggered a question. Like we're talking a lot about policy, and there seems to be a gap in terms of the creation of policy at the federal level and the requirements for states to actually implement the policies. And I guess by just straight up, is there any oversight, that Texas, and it could be any policy. This policy is not implemented as the federal legislation has intended it to be. Now what, right?
Yeah. Well, as you know, this is sort of at the heart of American governance. The way the Constitution sets up our powers at different levels, oftentimes the federal government doesn't have a lot of authority about what states do. And I think, the states that declined to expand Medicaid is a good example. We thought everybody would take that. $9 of $10 are coming from the federal government, but nonetheless, there's states, and Texas and one of them decided not to. Can't really make them do that. So often the remedies are at the state level, and sometimes that means working with the legislature, or sometimes that means working with the civil servants and the bureaucracy. Sometimes it means suing, and that is probably how states that have not pursued this, those are the remedies. It is less likely that the federal government will get involved. It's not that that never happens, but the federal government has limited ability to do that on many issues, and depending on the political atmosphere of the day, sometimes limited willingness to do that because states don't like the federal government telling them what to do.
I think we have time for one last question. I see you raised your hand, Andrea.
Yes, I actually wanted to tag along to the response on plan of safe care. So I'm with Baylor College of Medicine. I'm a research administration specialist, and back in 2020, I came onto the team for this reason exactly, for us to start a plan of safe care here in the state of Texas. So the version that we actually did with with after the amendment, we received funding, all that good stuff from SAMHSA. We actually saw that, and we started our pilot over at Santa Maria Hostel, which is a recovery center for families. So instead of separating mommy from children, everybody goes into treatment together. So that's where we started our pilot study, and we actually saw that it was very beneficial. Although here in the state of Texas, we have CPS, Child Protective Investigation, has a program very similar to Plan of Safe Care that's called very similar to that. So we had to change up the name very fast because everybody was like, nope, I don't want it. Nope. And we were like, no, we're not with CPS. So the take that we're trying to do here is called Family Care Portfolio. So that's meant for us to, following the model of Plan of Safe Care, but naming it Plan of Family Care Portfolio. The CARE stands for Coordination, Advocating, Recording, and Empowering Families in Texas. So if anybody on this call would like more information on that, please feel free to reach out. But I did want to tag along and say we're starting here in Texas, starting to try to do something for families. And you're absolutely right, Dr. Humphrey, and everything that you said. It's a hard road. But we're trucking along.
Good for you. That's really inspiring
you,
to hear. Thanks for saying that.
Well, that marks the hour, and I know there's probably more questions. This has been a great talk, Dr. Humphreys, and Dr. Humphreys, I know you're at a conference in Boston, so I appreciate you squeezing us in like this. I know you're busy, has a very busy schedule, but this has been great, and especially because we have a work group devoted to this topic, it's really great to see, hear from your expertise and learn. So thank you so much.
Thank you.
Yes, and so we'll post this recording on our YouTube channel, and yeah, with all of that, I hope everyone has a great Thursday, and thank you for attending another networking session.